My dad was a cancer doctor, and I remember very clearly, I told him about what was going on, and he said, well, Dave, if you need some help, if you need me to do something for you, just let me know. And I said, that's okay, Dad, I can take care of it. I've got good doctors down here. And then he called again, and he would say, I really don't mind. All the kids are out of the house. I can come and it was clear to me that he really wanted to come down and help take care of me. It made me realize what a great person he was, and it strengthened my relationship with him. And in fact, after the year after finishing my treatment, I just took 2 weeks off, which was totally unheard of for me, and went to Sicily with him and my mom and my sister for 2 weeks. And we had the most wonderful vacation I've ever had in my life. And the next year he died of a heart attack in Singapore. And so I'm terrifically grateful that this cancer had made me realize the importance of family and strengthened my bond with my parents. So really there's kind of 3 phases in your treatment. You're aggressively trying to cure this patient. You're willing to accept high toxicity for a small chance of cure. And then when you accept that there's no chance of cure, treating them with the point of prolonging their life, shrinking their cancer as best you can, stabilizing it as best you can. And then there comes a point when you either run out of options or they can't tolerate the treatment anymore, when you say, well, we're going to not directly address the cancer, but address you and your symptoms. We're going to treat pain, we're going to treat your nutrition, we're going to make you feel better. You come to a point when it's pretty clear to everyone that these treatments are just not helping and we need to rethink things. And that's assisted by my philosophy that I usually tell them on the first day. Like I said, you deal with cancer one day at a time. What are you going to do today? What's the best thing to do today? And when they come in to see me for cycle 3 of chemotherapy, we'll look at the x-rays, we'll look at the blood work, we'll look at the patient, and I'll say, today's not a good day for you to get chemotherapy, let's wait till next week. And, or I don't think this is doing you any good, let's give you a few weeks break and we'll look around for something new to try. And as long as we have this dialogue and interchange with the patient and the families, it works out very well, and that most of the time the patients are comfortable with these transitions, and I'm comfortable with the transitions as well. I eat better foods and I exercise, as I said, 6 days a week. And but I also realize that you can have silent problems with your heart, and as I exercise relatively vigorously sometimes, I don't want to just drop dead either from exercising too much inappropriately. So I've been seeing a cardiologist, and my heart function is not normal. It's measurably decreased by the treatment. But every so often I have a exercise stress test is just to show that everything looks okay. People think that clinical trials mean that they're being guinea pigs and that we're just testing things in them that don't have any chance of helping them. But that's not at all the case. This is the state-of-the-art treatment and we're trying to make it better. And the personal attention and care that patients get in clinical trials, I think, is better than the care and attention that they get on standard therapy. And it's a crying shame that only a few % of adult cancer patients go on to clinical trials. Even if your tumor is incurable, we can make you live longer and we can make you live better. And the drugs that we have are not optimal to do either of those things. They're toxic and they aren't as effective as we'd like. And the way we discover new drugs is through clinical trials. My name is David Carbone, and I'm a 5-year survivor of mediastinal large cell lymphoma.